Uh, Happy Tuesday. We're very lucky to have the clinical pathology conference today. So for just a reminder, it is essentially a review of an interesting case, but going through and finding the teaching moments through each and expanding our diagnostic skills, as you will, through this case. So we have a very interesting case that's going to be presented by our PGY2, Dr. Michael Jones, and we have two discussants, Dr. Anthony Hunter with Hematology and Dr. Waltuck with Rheumatology. So to just speak a little bit about our speakers, so Dr. Jones is, like I mentioned, PGY2. He hails from the UK, but he locally claims New Jersey as his home. He completed undergraduate studies at the University of Maryland and his medical degree at Rutgers University. He's an aspiring hospitalist. We hope to keep him here. Dr. Anthony Hunter is an assistant professor in the Department of Hematology and Medical Oncology at Emory. He completed his medical education at the Medical College of Wisconsin and then joined us here to complete his internal medicine residency at Emory. He completed his hematology and oncology fellowship at H. Lee Moffitt Cancer Center and Research Institute in Tampa, Florida, where he served as chief fellow in his final year. And since he has rejoined us in practice here and specializes in treating patients with leukemia and other myeloid malignancies, including myeloproliferative neoplasms and myelodysplastic syndromes. In addition, he is involved in research of molecular drivers and myeloid malignancies, including serving as co-investigator on an international effort to develop a novel prognostic system in chronic myelomonocytic leukemia. And our third speaker, Dr. Waltuck, truly needs no introduction as he has been a pillar of the rheumatology department for more than 20 years. After completing his medical degree, internship, residency, chief residency, and fellowship in New York, we were lucky enough to have him join us here at Emory University School of Medicine as faculty in 1993. And during his time at Emory, he served as the chief of rheumatology, as well as program director for rheumatology fellowship program for 10 years. He is a distinguished teacher as an associate professor with several teaching commendations from the internal medicine residency and physician assistant training programs here at Emory. He has also been named as Atlanta's top doctors by Atlanta Magazine. So a very distinguished panel of physicians talking with us today. So without further ado, I'll turn it over to Dr. Jones.
Wonderful. Hey everyone, thank you Lakshmi for those lovely introductions. So I hope we have an interesting case for everyone today. It's titled A Negative Bias, and there will be a lot of upfront data, but hopefully that will lead to a really nice discussion for us all. So let's see here. So just some learning objectives for today. We really have four main learning objectives. Number one, we're going to be talking about peripheral neuropathy, and we want to be able to identify some patterns for that. Two, we'll be talking about hypereosinophilia and learning about its differential and workup. And three and four, something we're all familiar with, but just reminding ourselves to recognize limitations in lab value interpretation and hopefully having a schema for the final diagnosis. So without further ado, our patient for today presenting with a chief concern, leg pain and numbness. And jumping into the HPI, so today we have a 52-year-old male. He's coming to the hospital with a 3-month history of progressive bilateral lower extremity pain and numbness. And his story really starts 3 months ago, at which time he started to have these biweekly episodes of burning pain in both of his feet. He felt like his feet were also swollen at the time, but there was no actual edema. All of these episodes, when he had them, were totally spontaneous, and they completely resolved overnight without really any intervention. Probably rightfully so, he thought it was kind of weird. So he visited an urgent care. There he was diagnosed with diabetic polyradiculopathy, and he was given a short steroid burst, and all the symptoms got better and didn't come back. That was the case up until about a month prior to presentation, when he was playing a few rounds of golf and had recurrence of those same episodes of burning pain in both of his feet. This time, however, those episodes, they weren't just in his feet, they kind of extended up to his mid-shins on both sides. He also had a new sensation of feeling really extreme colds over that same distribution, so much so that he asked his wife to kind of feel his legs and see if they were cold. She felt them to be warm. What was different during these particular episodes after playing golf was that he also had some numbness, weakness, and paresthesias of his left upper extremity from shoulder to hand. And really, like prior, all of those symptoms got better again without any intervention. He did see his PCP at that time, and we're not sure of all of the labs that were done, but we were informed of a rheumatoid factor being elevated and a white blood cell count of 15.9. So his symptoms kind of continued. 2 weeks prior, he had the onset of the same distribution of numbness in his bilateral feet, this time as well extending up to the mid-shins. New this time was he experienced the same paresthesias in his bilateral hands and felt that they extended up to his elbows as well. He also had some loss of function of all of his toes, and this led him not to be able to walk properly, but without any falls. 1 week prior to coming to the hospital, he also started to have some difficulty swallowing. He was having some postprandial epigastric abdominal pain and difficulty urinating. All of this really progressed until the day prior to admission when he had so many paresthesias, he was feeling so weak that he couldn't get out of bed, and this ultimately led to him coming to the hospital. Review of systems listed up here, and we can kind of walk through, but some of the pertinent positives. He did have an unintentional 20-pound weight loss over 4 weeks. He was having night sweats and chills over that same time. And honestly, a pretty unremarkable review of systems. Otherwise, I'll let you read through for a few moments here. On his HENT, he was having some mild nasal congestion. For his GI, he was having some intermittent loose stools. And then the neurologic, he had the paresthesias, as we talked about, but pretty unrevealing otherwise. And for his past medical history, he had hyperlipidemia and diabetes, both well controlled. What was interesting, he did have a history of asthma and eczema pretty much since his childhood. And almost every year, his allergies got so severe that he needed immunotherapy. His surgical history was notable for a recent nasal polypectomy. This was in the setting of a sinusitis episode that was very severe, a little peculiar. Medications, I'll leave up on the screen for just a minute, but nothing really out of the ordinary here. And no known allergies. For his family history, again, nothing too illuminating. Of note, there was no history of autoimmune disease or cancer. And for his social history, so he lived in Georgia. He was born in Korea. He lived in a couple different areas throughout the United States, the Northwest, Midwest, and Northeast. He worked an office job, didn't drink any alcohol, did not use any recreational drugs, and was a never smoker. And talking to him about an exposure history, really didn't travel anywhere, didn't have any sick contacts, and in regards to pets or animal exposures, really didn't have any. And so that was kind of the story of his presentation. And when he presented, here were his admission vitals. As you can see, pretty normal, no fever, normal heart rate, overall pretty unremarkable vitals. And that was kind of the story for his admission basic physical exam as well. As you can see, his oropharynx was clear. He didn't really have any evidence of lymphadenopathy. His cardiac and pulmonary exams were normal. His abdomen, he was a little bit tender in the epigastric area, but otherwise was soft and had no evidence of organomegaly. And his extremity exam was normal. As you all might be curious, I was curious kind of what his neurologic exam was like, so we can walk through that. He had no cranial nerve deficits. For his strength, there were some deficits. So for his upper extremities, in the right upper extremity, he had 4 out of 5 strength. And then his lower extremities had 3 out of 5 strength on both sides. His reflexes were completely normal. For his sensation, did a pretty in-depth exam and were able to find that he had impaired sensation to temperature in both of his lower extremities from the knees down, and his proprioception was impaired on his great toes bilaterally. His coordination exam in regards to his cerebellar screening, totally normal, though while watching him walk, he was just a little bit unsteady. And so his neurologic exam, kind of interesting. We got some initial labs, and they're kind of listed up here on the screen, and we can walk through some of the pertinent. So his CBC over here in the top left, notable for a white count of 28.2, with a differential of 42% eosinophils, and an absolute eosinophil count of just under 12,000. The rest of his CBC was pretty normal. His Chem7 down here in the bottom left was largely unremarkable. Up in the top right here, we have his coagulation studies, also normal. And down here, we don't see this all the time, but this is a fishbone for the extended chemistries and the liver chemistries. And over on the right here, we can see that his AST was elevated at 69, his ALT elevated at 81, and his ALK Phos elevated at 180. He also had mild hypoalbuminemia at 3.3 and a mild T-billy at 0.4. CPK was checked, troponin was checked, and TSH checked, all normal. And he had some initial imaging, as most people do. His EKG chest X-ray was normal. He had a CT of the T and L spine with these lower extremity findings, and there was no fracture or canal narrowing that was identified. And so really, like all of us face when it's kind of all the data that we usually get when we admit a patient from the emergency department. And our biggest job really as internists is separating signal from noise. So I think for me, when this case was seen by me and the rest of the medical team, there's really two big signals that jumped out that the final diagnosis really has to explain. The first was this subacute sensory motor polyneuropathy, which itself has its own very broad differential, and some are listed here, including vasculitis, nutritional deficiencies, malignancy, Guillain-Barré, and a whole separate signal number two that really also needs some explanation as well, including the inflammatory syndrome and the marked leukocytosis with eosinophilia. That itself has its own separate differential, which includes vasculitis, malignancy, and you could even consider DRESS with the liver inflammation as well. And so some additional orders were sent to kind of explore both of those hypotheses a little bit deeper. And on our next screen here, we can review some of those. So his A1C a little bit elevated at 6.7, ESR, CRP, both a little bit elevated, perhaps as expected. His vitamins were checked and normal. Down in the bottom left here, we can see he had a urinalysis and a protein creatinine ratio. No real evidence of renal involvement of this syndrome. And he had some additional imaging, including a CT chest, CT abdomen, and right upper quadrant ultrasound. All essentially were normal. And so to explore signal number one, the subacute polyneuropathy, neurology was consulted. And their initial impressions based on the sensory motor polyneuropathy and the eosinophils included a differential of Churg-Strauss versus some other rheumatologic process versus malignancy. To work that up a little bit, they recommended an EMG as well as an LP. The EMG was performed and showed an acute axonal polyneuropathy, which we'll talk about in a little bit. And the LP listed here, pretty much normal, nothing too exciting there. And so neurology, after seeing him, sort of reframed this case as mononeuritis multiplex, given the distribution of deficits, and recommended a further workup for vasculitis, which included some additional imaging that was unremarkable. And so at this point, I think it's a good time to kind of pause and talk about peripheral neuropathy. This is something I think we see all the time. And personally, I don't always do the best job of sort of qualifying it. So whenever I'm invoking peripheral neuropathy, it's usually because I'm thinking that my patient has some sort of sensory deficit, motor deficit, or both together. And this is an example of our patient here who does have some sensory and motor deficits in a various distribution. And so if you're thinking peripheral neuropathy, there's really three big categories to distinguish between. The first is a mononeuropathy, And as that really implies is pathology of one single nerve. So you have a patch of sensory or motor deficits. This is really common in compressive etiologies as well as trauma. So I think something that we're probably most comfortable with and see a lot is carpal tunnel syndrome would be a mononeuropathy. A second bucket under peripheral neuropathy, which we really don't see a lot, is something called mononeuritis multiplex. And what that is, as the name implies, is essentially pathology of a single nerve in multiple different areas. And the typical way that it presents is an asymmetric sensory motor polyneuropathy. And finally, I think probably what we are most comfortable with is polyneuropathy. This is typically asymmetric, what we see ascending of distribution of affecting all of the nerves. And this brings to mind things like diabetes, vitamin deficiencies, Guillain-Barré, things that we see quite often. So our patient, really with these asymmetric findings in very specific nerve distributions, had a mononeuritis multiplex. And since this is not something that we see too often, I think it's helpful to kind of think about the very specific differential that it invokes. And as you can see from the name, itis really implies some sort of inflammation. Whenever I think about inflammation, I'm usually thinking of three big categories: infections, malignancies, and autoimmune conditions. And specific to mononeuritis multiplex, these are the very big diagnoses within those categories that can cause this sort of pathology. And so with that in mind, some additional infectious and rheumatologic workup was sent, and we can walk through some of the findings here. So as you can see, the hepatitis B and C was negative, his HIV was negative, his stool cultures and ONP were negative. He did have positive findings for Toxocara antibody, as well as an equivocal schistosoma antibody. And his initial rheumatologic screen was pretty unrevealing as well, notable for a negative ANCA, negative ENA, normal complements, a low positive RF at 159, and a normal SPEP, UPEP, and kappa light chain ratio. And so if we walk through our differential again for mononeuritis multiplex, we've kind of eliminated a lot of the infections here with our serologic studies, and there was no real epidemiologic exposure for leprosy or Lyme. Malignancy is something that typically requires tissue, and so that was pending at this time, though as we know, amyloid was probably a little bit less likely to with the SPEP and UPEP. And our last bucket was the autoimmune conditions, which also seemed a little bit less likely with our initial screening. And so what was really helpful in this case, I think, is this figure here from the Lancet, in which if we follow from top to bottom, once you've decided you're on a mononeuritis multiplex, the next step is performing an EMG nerve conduction study. And on that third row there, you can see we, and with our EMG, have decided that this is an axonal pathology, and we've kind of already done the next step, which is considering vasculitis and other multifocal processes with our serologic workup, all of which were kind of unrevealing. And so the next step for progress is really pursuing a nerve biopsy. And so at that time, neurosurgery was consulted, and a nerve biopsy to sort of progress this case along as planned. Steroids were deferred. We also talked to ID about the positive Toxocara antibody and deemed that it wasn't really a cause of the current presentation. And so at this point, I think it's helpful to sort of reframe the problem and take a pause here. And so our problem representation for our patient right now is a middle-aged gentleman, history of allergies and asthma, who's presented with a subacute progressive mononeuritis multiplex, found to have very severe eosinophilia, elevated inflammatory markers associated with negative ANCA testing, pending a nerve biopsy. And so we've explored our signal number one. Our signal number two is our eosinophilia. And just to fill in the blanks a little bit more, our patient's peak absolute eosinophil count during his admission was about 32,000. And that's obviously very abnormal. So hematology was consulted to help us work through that differential. So at this time, I think what we'll do is hand over to Dr. Hunter, who will help us talk through the thinking and thought process of hypereosinophilia.
I'm not sure if you're able to unshare your screen from there. We go. All right, hopefully you can see that okay. So I'll give my kind of fairly brief but hematology kind of biased perspective of hypereosinophilia. So to start with kind of definitions and then some differential diagnosis. So eosinophilia, we consider any increase in the absolute eosinophil count above the normal range, which depending on the lab is usually about 350 or 500. Hypereosinophilia is a more substantial increase in the count with a specifically defined as a persistent absolute eosinophil count above 1500. Can also be biopsied, proving kind of marked tissue hypereosinophilia as well without that level of circulating disease. And then hypereosinophilic syndrome is again the same cutoff for the absolute eosinophil count, but specifically with tissue involvement that's causing organ damage. And this persistent criteria for the hypereosinophilia has varied a bit over time. The kind of classic definition was a persistence of at least 6 months. That's generally not widely used at this point. More accepted is kind of on 2 occasions over 4 weeks, but certainly in hypereosinophilic syndromes, especially with symptoms and organ damage, obviously we're not going to wait for that persistent criteria and proceed with workup and treatment. So to think about kind of differential diagnosis, at least from kind of my hematology perspective, I like to kind of break patients up into a couple of different groups or kind of baskets to put patients into. So the first, and what of course I'm most kind of worried and concerned for, are primary or clonal disorders of eosinophils. So these are in general hematopoietic malignancies where the abnormal eosinophils are truly part of some malignant clonal process in the bone marrow. And I'll elaborate that a little bit more on some of those diseases on the next slide. The next, and generally what is kind of the largest bucket that patients get placed into then is secondary or reactive causes of hypereosinophilia. These, I've had a relatively long list, not necessarily all inclusive here for you, certainly autoimmune disorders, infectious, and in particular parasitic, but certainly some others as well, allergic disorders, but a fairly long list of that can at least see some hypereosinophilia associated. The kind of general etiology for these is that the eosinophils are not necessarily themselves abnormal or part of some abnormal process. They are instead reactive in kind of a cytokine-driven sense with eosinophil promoting cytokines leading to that hypereosinophilia. After these, we get into some kind of more rare situations. There are very rarely some clusters of familial hypereosinophilic syndrome, which are not widely or fully understood yet at this point, but are very rarely seen. And then we have this lymphoid variant hypereosinophilic syndrome as well, which really does actually fit into the kind of bucket of secondary or reactive causes, but that I do kind of separate out. In this disease, we typically see an abnormal proliferation of kind of an abnormal T cell clone, usually with a type 2 T helper phenotype. And this abnormal and kind of proliferating clone secretes cytokines like IL-5 that promote eosinophils and ultimately lead to an eosinophilia. And it typically can present much like other eosinophilic disorders though. And then the last bucket that we're left with, kind of anyone who doesn't fit into these other categories, is diagnosed with idiopathic hypereosinophilic syndrome. In the case of no organ damage, we consider it hypereosinophilia of undetermined significance. And this, in the past, made up a fairly large proportion of patients. And over the last several decades, especially with kind of better testing for a number of disorders, especially a lot of our malignant disorders, this is a much smaller kind of group of patients than it used to be. So moving on to some of the hematologic malignancies that we see associated with eosinophilia. So the first that I kind of think about is this relatively rare but now kind of well-defined group of what we call myeloid lymphoid neoplasms with eosinophilia and gene rearrangement. So these are now well classified by the World Health Organization. And these include diseases that can present actually in a number of ways, mostly with an MPN-like phenotype, but occasionally acute leukemias as well. But defined by specific chromosomal rearrangements, usually fusions, and that result in activated tyrosine kinase proteins. So PDGFR alpha and beta are the kind of most well-known here. FGFR1 has been included, and the most recent that included in this category is a JAK2 fusion. I mean, there are some other less common ones that are not classified at least yet as their own diseases, but that we do see here. These have some very important therapeutic implications that I'll discuss at the end. Next, we're kind of left with a number of other WHO-defined myeloid neoplasms. So these are kind of any myeloid neoplasm. CML fairly classically has at least some modest eosinophilia, more commonly a basophilia associated with it. Any MPN, ET, myelofibrosis can all occasionally have some eosinophilia, relatively rare in MDS, a little more common in our overlap syndromes like chronic myelomonocytic leukemia. And then in subtypes, and particularly what we call core binding factor or inversion 16, which is a more favorable AML, can see some eosinophilia as well. Moving on to some kind of less common ones, then we have systemic mastocytosis. This is relatively rare, but a malignant or clonal disorders of mast cells. About 95% or so of these patients are classically associated with an activating mutation in the KIT gene. And that's what kind of drives this disease. They have usually a lot of systemic symptoms of mast cell release, but can see an eosinophilia associated with that as well. And then the kind of last myeloid disorder is chronic eosinophilic leukemia, NOS. This in and of itself is actually part of the MPN classification, but I kind of separated out here since it's kind of a unique entity. And this is really a clonal disorder where essentially they're not meeting criteria for any of these other myeloid diagnoses, but clearly have some sort of clonal marker, so some change on their cytogenetics or some gene mutation that we can detect. And then lastly, we do see this with lymphomas as well. It's not so much, in this case, of course, more of a reactive phenomenon where the eosinophils are not really part of that clone, but can see it as well. Hodgkin's is most classic for this, but can see non-Hodgkin's lymphomas as well, usually more so T-cell than B-cell lymphomas. So as far as kind of workup that I at least think about, you can tailor this, of course, on your patient and their presentation, but certainly a thorough history and exam is important, both looking for potential etiologies, but also any evidence of end organ damage from the eosinophilia. Obviously, a number of kind of basic laboratory evaluations. Tryptase is to help screen for, in particular, systemic mastocytosis. A bone marrow is typically going to be part of our workup on the hematology side of things. Pretty much standard, we will always get flow cytometry and conventional cytogenetics anytime we do a bone marrow biopsy. But a number of additional molecular testing we'll do for these eosinophilia patients. So we have a FISH panel, and in particular, you can see this is kind of detecting those specifically defined chromosomal entities. And this is particularly important. Some of these, especially PDGFR alpha, is a very small chromosomal deletion that you can't pick up on standard cytogenetic testing. So it's really important to send this usually by FISH or occasional PCR. And we'll send BCR-ABL to look for CML. And we have a myeloid mutation. This is a 75 gene sequencing panel that we send in the vast majority of our myeloid patients here and can help detect mutations that at least document some sort of malignant or clonal process going on in the bone marrow. And we can send a KIT mutation to look for mastocytosis, and then we'll often send T-cell receptor rearrangement studies as well to look for T-cell clonality, including that lymphoid variant of hypereosinophilic syndrome. Certainly a number of other things, of course, to consider for these kind of secondary causes. So usually an autoimmune workup, at least some screening is going to be part of this workup. And I often send IgE as well as IL-5 levels. IL-5 can be elevated in a number of things, but including that lymphoid variant HES, we typically see this elevated. Certainly an infectious workup needs to be considered, again, tailored to some degree based on kind of exposures, but certainly strongyloides is often sent because you can see acute worsening with high dose steroids that most of these patients get. And then last, and what's kind of important is to evaluate for any evidence of end organ dysfunction in these patients. So typically cardio and pulmonary involvement is some of the most catastrophic end organ we see in these patients. So usually some at least basic studies for cardiac involvement, often a CT, chest, and PFTs we'll consider, and then can also consider some other imaging to look for splenomegaly, adenopathy, and things as well, and evidence of malignancy. As far as some of the clues that I kind of used in your very kind of basic workup to kind of think about when we should at least factor more so in a hematologic malignancy. So constitutional symptoms, kind of your classic B symptoms of lymphoma, obviously seen in lymphomas, also very common in myeloproliferative neoplasms. Not necessarily specific, but certainly, a lot of weight loss, these night sweats and things should certainly weigh you into this. On the CBC, of course, typically all these patients are going to have an eosinophilic predominant leukocytosis, so that's not really unique to anything. But other count abnormalities are really important to recognize. So anemia, thrombocytopenia, or thrombocytosis is common as well in MPNs and CML. So other count kind of cell lines that are abnormal. Presence of a lot of immature granulocytes, especially myeloblasts on the diff, should really factor into that. Other abnormal cells, so basophilia, quite common in CML, monocytosis, very common in CMML, and certainly highlighting kind of an abnormal marrow process, and then presence of atypical, particularly dysplastic cells when we review the smear. Elevated B12 levels in the past were actually part of some diagnostic criteria for myeloid diseases, especially with eosinophilia, and relatively common in some of these myeloid disorders due to production of haptocorins by clonal granulocytes. Can see adenopathy, splenomegaly, in particular with lymphoma, but also MPNs. Sex is something to consider. So PDGFR alpha rearrangements in particular, over 90% of these patients generally are male. Not quite as strong for PDGFR beta, but certainly think about these diseases more in males. And then just to point out, organ damage doesn't necessarily have to follow a specific pattern and can really be seen in any disorder that can cause a dramatic increase in the eosinophil count. So then just briefly to kind of touch on management, of course, treatment we're going to typically tailor to whatever we discover as the underlying etiology for things. Of course, our secondary causes, we're going to treat that underlying disease. And for the most part, regardless of etiology, steroids, usually about mg per kg per day, is going to be very effective frontline therapy, and can see a pretty dramatic drop in the eosinophil count. In just a couple of days, you'll see this normalize from even in very, very high eosinophil counts. Can actually, and for that sense, affect some of your diagnostic, especially morphologic type testing. So do you want to try and kind of expedite that work if you're starting steroids? And then just to kind of highlight the treatment for some of our myeloid diseases. So again, these specific chromosome arrangements are some of the most important to kind of identify. In particular, PDGFR alpha and beta are exquisitely sensitive to imatinib. So targeted approaches, actually much lower doses even than we use in CML. Historically, a very aggressive disease. Now 10-year survival rates in the 90% range, with the vast majority of patients having complete molecular remissions on therapy. FGFR1 and JAK2, we do have potential targeted agents for these. These are much more aggressive, so we do consider transplanting most of these patients as well. Other, WHO-defined neoplasms, AML, MDS, will kind of treat as we otherwise would treat that underlying disease. Kind of likewise for chronic eosinophilic leukemia, it really is an MPN, so we'll treat that with typical MPN type therapies. Hydroxyurea can be an effective second-line agent after steroids. Consider pegylated interferon. We will occasionally transplant these patients as well. And then we're kind of left with our more idiopathic or lymphoid variant hypereosinophilic syndromes. Steroids are generally first-line agents for both of these and can see very good responses, but a lot of patients will require steroid-sparing agents eventually. So then we'll, again, using some of our more kind of MPN type therapies, hydroxyurea has been shown to be effective in the second-line setting, interferon. Mepolizumab is now approved for idiopathic HES. This is a monoclonal antibody against interleukin-5. IL-5 is, again, kind of an eosinophil-promoting cytokine and can be effective in these patients as well. And then in these patients who don't have any end organ damage, especially if they have a more moderate increase in the eosinophil count, no clear underlying etiology, sometimes we can just monitor these patients for any progression. But with that, I'll stop sharing here and send it back to you guys.
Wonderful. Thank you, Dr. Hunter. I am so happy Hematology was on board for this case. It's really a powerful diagnostic filter, eosinophilia, and I think exploring it is definitely helps make some diagnostic progress. And so returning to our hospital course here. So as Dr. Hunter suggested, bone marrow biopsy was recommended to evaluate for possible hypereosinophilic syndrome or eosinophilic leukemia. And there was some evidence of end organ damage, definitely with the liver inflammation on our Chem7 and some nerve involvement too. And EGPA was on the differential, but ANCA was negative, if we all remember, so felt to be less likely. As Dr. Hunter suggested, tryptase, EBV serologies, and a peripheral flow were also ordered. And a lot of that workup started to trickle in. The tryptase was normal. The EBV serology did not show any active infection. The IgE we were able to see was elevated at a neighboring hospital. IL-5 was not collected. The peripheral blood flow was essentially normal, apart from there being very high amounts of eosinophils, kind of as we expected. Bone marrow biopsy was performed, and perhaps as expected again, was notable for marked eosinophilia, but negative for any sort of malignancy. And there were some FISH studies sent as well that were negative. And so we've kind of explored the hematologic side of things, and the workup largely has been negative thus far. And all that's outstanding really is the nerve biopsy. And so kind of didn't know what to do. We were kind of waiting for our nerve studies to come back. And what was interesting were the developments that happened over his hospital course while that nerve biopsy was pending. So while awaiting those diagnostic studies, the patient unfortunately developed acute renal failure. This was due to neurogenic bladder, and it led to acute encephalopathy as well as acute hypoxic respiratory failure requiring an ICU stay. While in the ICU, the patient had an inferior STEMI, was taken immediately to the cath lab for a left heart cath, which was completely clean, and ultimately was deemed to have a possible coronary vasospasm, possibly secondary to a vasculitic process. Cardiology didn't have any primary concern for eosinophilic myocarditis. which is a feature and end organ manifestation of primary HES. They kind of felt this way due to the negative troponin, the preserved EF, and the rapid resolution of symptoms. And so, as we normally do when we can't figure things out, we usually consult our rheumatologists who help put everything together. So rheumatology was consulted, and really given the whole clinical picture, the findings, the laboratory and imaging data to this point, felt that this is a really strong case for EGPA as the underlying diagnosis, and before nerve biopsy was obtained, recommended starting steroids empirically for treatment. And so steroids were started based on a clinical diagnosis. And that kind of leads us to our final diagnosis, which is ANCA-negative eosinophilic granulomatosis with polyangiitis. And for this patient, it was complicated by mononeuritis multiplex, acute renal failure from the neurogenic bladder, and obstructive uropathy, as well as an inferior STEMI secondary to coronary vasospasm. And the nerve biopsy was eventually performed, and it showed a necrotizing myopathy, intense perivascular inflammation, overall concerning for vasculitis, and consistent with a diagnosis of EGPA. Of note, no eosinophils were identified on the biopsy. That's of course because high-dose steroids were started. And so at this point, I think I would love to hear from our rheumatologist for today, Dr. Waltuck, who's going to tell us some more about EGPA.
Okay, I'd like to give you, as the slide says, a rheumatologist's perspective on this case. I was actually the consultant who saw this gentleman when he was in the intensive care unit with his renal failure and encephalopathy. Next slide, please. Just a little bit of a historical note. This is now called EGPA, but for many, many years, and certainly when I was in training, it was called Churg-Strauss Vasculitis, named after Jacob Churg and Lottie Strauss, who were two Central and Eastern European Jewish refugees who came over immediately before the Second World War. Dr. Churg was mostly a renal pathologist, and Dr. Strauss was mostly a pediatric pathologist. And in 1951, they described 13 patients who had previously been diagnosed with polyarteritis nodosa. And they said that these patients were distinctive in that they had tissue eosinophilia, they had necrotizing vascular lesions, and they had extravascular granulomas. Now, in most cases, we are not able to demonstrate all of these lesions in the same patient, but Drs. Churg and Strauss were. When I was in training, this was also referred to as allergic angiitis and granulomatosis. There is some controversy in the literature as to whether Dr. William Osler in the proceedings of the Johns Hopkins Hospital in 1900 described the first case of Churg-Strauss. He described a young man who he said had eaten abundantly of pork and had asthma and eosinophilia. Dr. Osler mentioned that he was not able to determine whether the pork was cooked or raw because the patient was a Pole and it was difficult to understand him. Obviously, Dr. Osler did not have our degree of transcultural sensitivity. In 2012, the American College of Rheumatology renamed this EGPA, eosinophilic granulomatosis with polyangiitis. Now, we in rheumatology have lost a number of our eponyms through the years, some for very good reasons. Wegener's Reiter syndrome. Hans Reiter and Friedrich Wegener were both Nazis and both joined the Nazi Party prior to 1933 when Adolf Hitler came into power. A lot of people joined the Nazi Party later in the 30s just as a way of getting ahead, but these were true believers. And Dr. Wegener, in fact, was a member of the Sturmabteilung, or the SA, or the brown shirts. But we've also lost a number of other named syndromes. Hanoch-Schönlein purpura is now IgA vasculitis. Of course, we still have Heberdins, Bouchards, Jacquards, Raynaud's, Sjogren's, Takayasu's. I think a lot of these names are actually worth something. They're very evocative. Say, for example, Jakob Creutzfeldt or Alzheimer's, I think means a lot more to people than just a description of what the disease actually does. Can we move on to the next? This is Jacob Churg. This, I think, was probably in his more mature years, probably judging by the width of the tie, the 1970s. Next slide. Jacob was born in 2010 in Belarus, which was actually part of Tsarist Russia at the time. He graduated from the university in Wilno, Poland in 1933. And he emigrated to New York in 1936, where his uncle, Louis Chargin, was a chief of skin disease at Mount Sinai. Jacob devoted himself mostly to renal pathology, although he was also very important in the description of asbestosis in the lungs. Ironically, he wrote a review of Wegener's granulomatosis in 1954 and was actually instrumental in giving it that eponym at the time. Next slide. This is Lottie Strauss. She was a pediatric pathologist. Next slide. Lottie was born in Nuremberg in April of 2013 to a Jewish family. She started her medical studies in Germany and then, seeing the writing on the wall, relocated to Siena, Italy. She came to the United States in 1938, where she studied microbiology at Beth Israel. Her specialty was pediatric and perinatal pathology, and there is still a Lottie Strauss Prize given every several years for excellence in pediatric pathology. There actually is also a Jacob Churg-Strauss, a Jacob Churg Prize, which is given every several years for renal pathology. For those of you who want to learn more about Lottie, I will be inflicting a much longer and more detailed talk on the rheumatology service at some point. Turns out there were actually two Lottie Strausses born in 1913 to Jewish families in Germany, both of whom emigrated to the Upper West Side of Manhattan, one right before the war and one right after the war, and both became fairly well known. Churg-Strauss patient characteristics. These patients tend to be middle-aged or older. None of these are 100%. This has been described even in a pediatric population, but in general, these are people in their 40s or older. They almost always have a history of asthma, and that asthma is often severe. It's often late developing. It may develop in middle age rather than the typical adolescent or pediatric asthma. And it's often quite difficult to control and in fact requires steroids. Again, there are exceptions to all of these. There are cases in which the systemic features in eosinophilia develop concurrently with the asthma. There are even a few cases where the asthma develops after the systemic features in the eosinophilia. Nasal polyposis, which was present in this man, is also tends to be part of the phenotype. As time goes on, they develop more systemic features. Next slide. You can think of EGPA as sort of a super eosinophilic asthma. This is kind of an eosinophilic asthma that is transformed almost like the Incredible Hulk into some giant green monster that tears off its shirt and runs rampant through all of the other organ systems. features such as fevers, rash, weight loss, peripheral neuropathy, and very importantly, and we'll come back to talk about this a little more, gastrointestinal and cardiac involvement, which are not typical of most small vessel vasculitis. There is very dramatic peripheral eosinophilia, as there is obviously in this case. There is a significant question as to the role of leukotriene inhibitors in this syndrome. And you will notice that our patient was on montelukast. When the leukotriene inhibitors became available, a number of cases of the rapid development of EGPA after the initiation of leukotriene inhibitors were reported. The question is, are the leukotriene inhibitors actually stimulating this, or are the leukotriene inhibitors a marker for severe asthma? And do they then allow the taper of the steroids, which may then unmask what becomes a more systemic process? There is significant question about this, and there is at least a biologically plausible mechanism whereby montelukast and zafirlukast could be pro-inflammatory. They may shunt leukotriene synthesis into LTB4, which is very inflammatory. Interestingly, another leukotriene inhibitor, Xyluten, which inhibits at a different level and inhibits all leukotrienes, has not been associated with EGPA. The ANCA may be positive or may be negative. In almost every collection, though, I would say every collection of patients with Churg-Strauss, the majority of patients are ANCA negative. So I think that's one of the things that really threw people off in this case. I think had this patient been ANCA positive, I think things could have progressed a lot more rapidly. Usually maybe a third to 40% of patients with EGPA are ANCA positive. Next slide. The organ involvement, as we said before, nasal polyposis, allergic rhinitis, chronic sinusitis usually precedes the lower airway involvement with pulmonary infiltrates and eosinophilia, often very migratory and transitory infiltrates, sometimes more long-lasting findings such as ground glass opacities and bronchiectasis. Very importantly, the cardiac and gastroenterologic systems are very much involved in EGPA, much more so than other small vessel vasculitides. Gastrointestinal perforation actually is fairly common. In fact, I remember the first couple of cases of Churg-Strauss I saw when I first came here in the early Pleistocene period involved small bowel perforations. And you can imagine that that was a very challenging situation when you're trying to initiate high dose steroids. Peripheral nerves are involved with what's classically mononeuritis multiplex, as was mentioned by Dr. Jones. In this case, if you get enough single named nerves involved, it can look like a polyneuropathy, but in fact, it's not. The renal disease in this vasculitis is rare and generally mild, very much in contradistinction to microscopic polyangiitis and GPA, in which the renal disease is often the most traumatic manifestation. Next slide. There is hypothesized to be some difference in manifestations between the ANCA positive and negative patients. The ANCA positive patients act more like classic systemic vasculitis with constitutional symptoms, peripheral neuropathy, glomerulonephritis, and a high rate of relapse. The ANCA negative patients act more like an infiltrative eosinophilic process, which involves the pulmonary system, gastrointestinal system, and cardiac system, and interestingly is associated with somewhat higher mortality. So as you would expect, the ANCA positive pathology is more classic necrotizing vasculitis, fibrinoid necrosis. The ANCA-negative pathology is more vessel infiltration with eosinophils without vessel destruction. Next slide, please. IL-5 as a therapeutic target, as Dr. Hunter mentioned, IL-5 is very important in generating and activating eosinophils. IL-5 is produced by activated T cells of the Th2 phenotype, results in maturation, activation, and survival of eosinophils. IL-5 blockers cause a very rapid reduction in eosinophil count and are very effective in eosinophilic asthma. Next slide. There actually was a study from the New England Journal in 2017 called the MIRA study of mepolizumab Nucala versus placebo in relapsing or refractory EGPA. Suffice it to say that it was quite effective. There was greater accrued time in remission, more patients with remission for at least 24 weeks, longer time to relapse, and fewer relapses. Now, interestingly, in this study, only about 10% of the patients were ANCA positive, just making the point again that that is not part of our diagnostic criteria. Next slide. Therapeutic questions. Mepolizumab is now approved for EGPA. Benralizumab, or Fasenra, which is an IL-5 receptor blocker, has not been approved, but there are trials ongoing right now, including one trial in which my colleague, Dr. Athantiliakos, is recruiting patients. Omalizumab, or Xolair, the anti-ILG agent, may be effective. At least there has never been the report of the development of EGPA on someone on omalizumab. Rituxan, as we know, is generally effective for ANCA-associated vasculitis, has not been proven to be effective for this, but certainly there's a reasonable mechanism. And what we really look for nowadays, the holy grail of treatment of vasculitis, is to do it without steroids at all. Now, when Wegener's granulomatosis was first described, the life expectancy was about 5 months. That was pre-dialysis. When steroids came into being, it moved up to 12 months. And in the early 1970s, Dr. Fauci at the NIH, in a previous incarnation, introduced cytotoxic drugs such as Cytoxan. And for the first time, we actually had long-term remission in vasculitis. Unfortunately, we still have to use a lot of steroid, which causes a lot of toxicity. There is a lot of interest in avoiding steroids now. And Avacopan is a new medication which has been approved for ANCA-associated vasculitis, and some people think it can take the place of steroids, which would be wonderful. Next slide. This patient improved very dramatically and is left just with some subtle weakness. Next slide. I think one of the things I think about a lot in this case is the relationship between diagnostic certainty and optimal outcome. As a hospital course progresses, one would hope that the diagnostic certainty increases. Tests come back, more laboratories are done, radiographic studies are done. Unfortunately, there is also a time limit to some of this. The patient may be accruing significant damage during this period of time. Now, I think we should give ourselves a lot of credit because we implicitly make this calculation every day. We decide how much certainty do we need before we pull the trigger and start treatment. This is a very difficult decision to make. Often we may require the help of other specialties, like in this case, we can't do a nerve biopsy. How much does that influence how quickly we make our decision? For perfect example is giant cell arteritis in rheumatology. We are not able to do a temporal artery biopsy. We have to rely on another service to do this. But we have to make a decision when we first see the patient, how high are pretest probability is of this patient having the disease. If a patient presents with some vague headache and muscle aches and a slightly elevated sedimentation rate, we are not likely to empirically treat that person. We may try to send them for a temporal artery biopsy. If the patient presents with fevers, headache, jaw claudication, and visual disturbance, we will empirically treat that person, regardless of whether it may interfere with the ultimate diagnostic specificity. I don't think we should worship at the altar of diagnostic specificity at the expense of the patient. In this case, I think in this person's case, I think you can make the case that we were certain that he had a systemic inflammatory process which was aggressively involving his peripheral nervous system, that it was not a malignancy, that it was not an infection. And at that point, I think you can be pretty comfortable in initiating steroids empirically. Next slide. Thank you very much for your attention.
All right. With that, we are near the top of the hour. So if there are any questions, please pop them in the, yes. So the resolution of this case, Dr. Waltuck has been seeing him in clinic. So I'll let you know. It seems like his eosinophilia count came down completely. It is no longer detectable. He had some pretty remarkable response. He was discharged to acute rehab following that hospitalization with improvement.
He has a dense right foot drop, slight left foot drop, and a little bit of weakness in his left hand, but he has returned to work and he has gained about 20 or 25 pounds and really is doing remarkably well.
We have a comment in the chat box. Wonderful discussion. I always worry about endomyocardial fibrosis in hypereosinophilia patients. Has this patient had this checked with a cardiac MRI?
I don't believe so, but I think you make a very good point, because as we said, that infiltration of eosinophilia in both the gastrointestinal tract and the heart are very important. In fact, this patient, we glossed over this, actually had another admission several weeks after his discharge with a presumed perfed bowel with a large fluid collection, which was septic in his abdomen. Now, we never identified where that perforation was. It was drained, treated empirically with antibiotics, and he recovered. But I would presume that there was some eosinophilic infiltration in his gastrointestinal tract.
Awesome. All right, we're at the top of our hour. Thank you everyone for joining. Hope you have a wonderful rest of your day. Thank you for our three speakers, Dr. Jones, Dr. Hunter, and Dr. Waltuck, for talking with us and teaching us. Thank you. I know there's two of you that are on service and one of you that's in clinic right now. So really appreciate taking your time out of your day. Thank you.